Okay, I skipped ahead a slide, but cardiac muscles are much more different and unique compared to the other muscles in our body. And the four properties of cardiac cells, this actual slide that you see in front of you here, is the reason why. And they have the actual cells of the cardiac musculature have four different properties. There are automaticity. Automaticity basically means it's the ability of some cells to actually initiate their own electrical impulse. So if one cell is not necessarily firing, another cell can fire off in order to sustain good cardiac output. We have contractility, is the ability of the myocardial cells and fibers to contract and stretch in response to an electrical impulse or electrical stimulus. Conductivity is the ability of a cell to transmit electrical impulse somewhere else. So this means that when that electrical impulse does fire, all the cells kind of carry that impulse through them so that they're all basically firing at the same time. And then we have excitability, and it's the actual excitability that gets our cells to become excited to that electrical stimuli in order for it to sustain the contraction and the rest, the systolic and the diastolic of the actual heart motion itself. Make sure you guys know these for the exam. You guys will see these on your next exam as well. When we're talking about the actual electrical system of the heart, there's basically three different points where I want you guys to kind of remember. The SA node is known as the primary pacemaker. If your SA node, which is found, you guys can see on the slide here, found in the right atrium area of the heart, is the primary pacemaker. If your SA node is firing, more than likely your heart rate is greater than 60 beats per minute. Okay, we say about 60 to 100 because that's the normal range of a normal adult heart rate. The AV node, so the SA node fires and actually sends the electrical stimulus to the AV node. The AV node is the secondary pacemaker. If it's only your AV node firing, your heart rate's anywhere between 40 and 60 beats per minute. And then the ventricles are actually the final pacemaker. If the ventricles are the only thing that are firing, it's anywhere between 20 and 40 beats per minute. Obviously, that is not sustainable with life for most adults, unless somebody is in very good shape, and their resting heart rate is usually down in the 40s or 30s or possibly 20s. But the ventricles are the final pacemaker. And this is all kind of just talking about the electrical system of the heart. I'm going to get into it a little bit more on these next couple of slides. So when we're looking at a basic ECG or EKG, however you guys say it, you have a P wave, as you guys can see on the right hand chart here, and then we go into what's called the QRS wave, and then we have the T wave. The P wave is actually when the atrials fire. So it's basically when the SA node has fired and the cells in the atria are starting to prime the ventricles. Once the ventricles fill up with enough fluid, also known as blood, right? Once the ventricles fill up with enough fluid, at that point those cells kick off the QRS. The QRS is the actual ventricles firing off or depolarizing. And then they kind of go to rest. The T wave is where the ventricles actually rest. They kind of, it resets itself and then it goes right back in to the P wave again. So really this is all controlled by electrolytes, guys. This is sodium and potassium and calcium and magnesium, all kind of doing their thing, all kind of doing this big old basically chemistry set, which is your cardiac muscle cells with the nutrients that it's getting in order for it to fire off. For a normal heartbeat, you will get a P wave, a QRS wave, and a T wave. This next slide actually kind of shows the cardiac cycle, and I don't think it's going to actually show you guys in this presentation. You guys have to download this PowerPoint and actually look at PowerPoint, this slide specifically, so that you guys can kind of see the graphics involved with this. So basically what happens is there's a sequence with cardiac depolarization and repolarization. So the SA node fires. Once the SA node fires, it takes that signal and it goes down to the AV node. The SA node firing gives us the P wave. Okay, the AV node holds on to that signal. It kind of grabs that electrical stimulus and it holds on to it just for a split second. And the reason why it does that is what's known as atrial kick. The atrias are filled with blood. They're starting to drain that blood into the ventricles, and we're just waiting for those ventricles, for that blood to, all the blood to be released from the atrias into the ventricles, so that those ventricles can fill up with as much blood as possible. So the AV node holds on to that signal just for a second, in order for all the blood to be drained out of the atrias into the ventricles. From there, it goes down into what's called the bundle of His. Okay, so the signal goes from the AV node down to the bundle of His, and then you guys can see on this slide the right and left bundle branches. Okay, the right and left bundle branches start to depolarize. It kind of wraps around the ventricles, and then it fires off the ventricles. It depolarizes the ventricles, so you get the squeeze of the ventricles. That's what gives us the QRS. And then everything kind of resets for the T wave, which is known as repolarization, in order for the heart to be able to fire off again. Okay, so at the basic level, you guys are responsible for knowing a couple heart rhythms. These are the first two heart rhythms that you guys are to know. When we're talking about somebody who is tachycardic, their heart rate is faster than 100. And as you can see on this ECG, you guys can see the R waves, which are the kind of pointy ones that looks like it might hurt to sit on. Those are technically the depolarization of the ventricles. That's how we get the heart rate of our patient. So obviously, the closer that those R waves are together, the faster the heart rate actually is. Compared to the bradycardia, which is any heart rate that is lower than 60 beats per minute, you can see how those R waves are spread out. However, also notice with the bradycardia that you can see the P wave, you can see a QRS, and you can see a T wave, right? So the slower the heart rate, the further apart the actual R waves are. The faster the heart rate, the closer the R waves are. Some terminology for you guys. I will not have you guys actually do the math for the test. I want you guys to just know these definitions. Cardiac output is the amount of blood that's pumped by the heart in 1 minute. Cardiac output is the actual heart rates times what's called the stroke volume. The stroke volume is the amount of blood that is pumped out with each contraction. So for a normal, average-sized adult male, normal stroke volume is about 70 cc's, 70 cc's of fluid. So if we take that 70 cc's and we multiply it by 70 beats per minute, we come right out to about 4,900 mLs, or 4.9 liters, which is what our cardiac output is. And the average male adult has anywhere between about 5 or 6 liters of actual fluid in the body. So we're pumping right around 5 liters per minute in our average adult male size, based on a heart rate of 70 beats per minute and a stroke volume of 70 cc's. So the number one problem with any kind of coronary artery disease, or what we call CAD, and remember, coronary artery disease is kind of like COPD with respiratory. It's a general broad term of numerous differential diagnoses with cardiac related pathologies. Okay, but the big one is arteriosclerosis, and arteriosclerosis is actually the thickening or hardening of the artery walls, right? And this is happening from day one with us. Our diet affects this, our actual exercise affects this, right? Dipping those Wendy's French fries and that chocolate frosty really has an effect on this, or all that good Taco Bell that you guys eat or whatever, right? But basically, this is plaque and fat buildups in our large vessels. It's the plaque and fat buildups, also known as atherosclerosis. Okay, so arteriosclerosis is the thickening or hardening of the actual arterial walls, where the plaque and fat deposits in these large vessels due to the arteriosclerosis is known as atherosclerosis. Don't get those two mixed up. It's really easy to do. So the problem is we get all these fat deposits or plaque deposits on the inside of our vasculature, and these plaques can break off and they kind of start to form a clot, right? So these clots form over time, and they can get lodged in our legs. It's usually where they do get lodged is what's known as a deep vein thrombosis. And they continue to get bigger and bigger and bigger. And eventually the back pressure is going to have that clot kind of break off, and that clot's going to travel. Most of the time, if that clot travels to our heart and it gets implanted there, we're having a heart attack. If that clot travels to our lungs and it stops there, we are suffering a pulmonary embolism. If that clot goes to our head, we're having a stroke, or what's known as a cerebral vascular accident, which we're going to talk about in neurology in a different lecture. But really what this does is, because of the arteriosclerosis, is our vessels can expand in order to regulate the actual flow of blood to our tissues. So we can start developing ischemia. You will see the term there, ischemia, on the bottom of this slide. That's just the lack of blood flow to our cells, and something known as angina. We're going to talk about angina here in a minute. So arteriosclerosis and the actual atherosclerosis that's produced because of the arteriosclerosis can really give us some problems. And again, this starts talking about coronary artery disease, or how we label it as CAD or CAD. The two main disease processes in the coronary artery disease are known as angina, or an acute myocardial infarction, also known as an AMI, also known as a heart attack. And an acute myocardial infarction can lead to a congestive heart failure, which we already talked a little bit about in respiratory, and we're going to talk a little bit more about it here in cardiac. This can lead to strokes because we are forming clots. We have all these plaque and fat buildups that are kind of lining our walls of our vasculature, and eventually these are going to break off and they could develop a stroke. We're going to talk about aneurysms, where the actual walls of our vasculature, usually because of high blood pressure, the pressure in the arteries are so high that it actually starts to denaturize or break down the inside of our vessels, creating a bubble. And if that bubble pops in our arteries, we're going to have an arterial bleed real quick with our patients. And then hypertension. Hypertension is also known as high blood pressure. Hypertension is also known as the silent killer, because you can live a whole lifetime with hypertension and all of a sudden you die. So we'll talk about all of these individually coming up here. So that arteriosclerosis of the coronary arteries, again, leads to the coronary artery diseases. And it's the plaque and fat buildup, and it progressively starts to narrow the actual heart blood vessels, and this leads to deoxygenation or decreased oxygen to that muscle. If we have a decreased oxygen to that muscle, that area is going to start to die off. We are going into a state of shock, and we are not going to be able to perfuse that area of the heart. And because we're not able to perfuse that area of the heart is not going to be able to pump and help circulate and help keep the pressures for perfusion that we need to get that blood all the way down to our big toes. So when we're talking about risk factors for coronary artery disease, there are some uncontrollable and some controllable. Your uncontrollable ones are basically hereditary, right? Your genetics, your ethnicity, okay? Where did you guys come from has a lot to do with it as well. And then your sex, your gender. Males are definitely at higher risk. However, the risk increases for women after they reach menopause. When we're talking about controllable risk factors, any kind of uncontrolled hypertension. So people that have hypertension and they don't take medications for it, or people that have high blood pressure and they don't regulate their salt intake or don't drink enough water. Those are controllable risk factors. That it's considered a controllable risk factor for actual hypertension because it can be controlled through pharmacological measures. Diets that are high in fat, right? Those Taco Bells, those Del Tacos, the KFCs, trying to think of some other ones, right? The Mickey D's, the Burger Kings, right? All delicious in their own way, but they are extremely bad for you, so be careful what you're eating. Smoking increases your risk tenfold, guys. Smoking is not the best thing for you. Sedentary lifestyles, basically, get out and get some exercise every now and then. Birth control pills, especially in our females. And the problem with birth control pills is the fact that when you guys are taking birth control pills, it actually increases your clotting factors almost tenfold. You are more prone to blood clots because of the birth control that you guys are on. And then people that actually have diabetes, and we'll talk about diabetes when we get to our endocrine lectures.